further ado, may I invite you to come up to the floor to talk us through the FH Paediatric screening campaign.
Thank you very much, Nicola. How do I move the slides forward? I will talk a little bit about the FH Pediatric screening. I will start with some background, and then Nicola will continue a bit more focusing on the Prague declaration. Is it working? Not sure if that one is working. Oh yeah, I'm sorry, it has some latency. So this is one figure that was published this year. Together with Sam, Bert, and others, we tried to put as many facts related to FH and FH screening to the one figure. It's probably now widely comprehended in this group, but still, perhaps I can briefly go through it. FH is a most common inherited life-threatening human disorder, human genetic condition with a prevalence of 1 in 300. If we compare it, for example, all the inborn errors of metabolism cumulatively are around 1 per 1,000, and FH is a inborn error of lipoprotein metabolism is 1 in 300. Of course, we're talking here about the heterozygous FH. So if we are taking perspective of genetic disorders, we are having here extremely common genetic disorder. We know that early CVD risk is I would say, at least 10 times higher. Of course, it's a spectrum of phenotypes. It could be a few times higher to much more than 10 times higher, but on average, it's over 10 times higher. But what is important, the complications are preventable if, of course, the diagnosis is established in the right time. Only around 5% kids globally are currently having the right diagnosis, which means that around 2 million people and 500,000 of children only in Europe are without the diagnosis. So here we also need to know that the conditions is it inherited in autosomal dominant way. So that means that there's a 50% chance that the condition is passed to the next generation. And there's also 50% chance that a child has a sibling with the same condition, which is, I would say, quite a lot. And here, that's the reason we are here talking about really the family-centric care that's important for people or patients, as you like, with FH. And pediatric screening is here instrumental that providing the benefit for the whole family, not just for the child, but also with each child, one of the parents will also have the same conditions. So, I mean, in the short term, we might even claim that there is a greater benefit for the parent as compared to the child, because the parent is usually not aware of the condition and already in the age group where that age group of young adults is especially prone to complications. And two, generally speaking, I will talk a little bit more about it later. Two solutions exist, two types of solutions. One is universal approach, which means that you measure cholesterol in all children at a specific age. And then based on your program, you either genetically or some other way confirm or exclude the diagnosis. If you confirm the diagnosis, you can also very easily confirm the diagnosis in a child with usually higher levels. The other approach is cascade screening. So there is usually presumption that you have an index case here. For example, in the Netherlands, they really explored around on the terrain For the first index cases, they measured cholesterol to the whole villages, and then they roughly explored for each person where they discovered diagnosis, they roughly explored all the family pedigrees, family trees, and for one person, they found more than 10 other persons. And so this is the classic example of the Netherlands. Even we know all that, still around 90% of adults and over 95% of children with FH are still undiagnosed. That slide is now a little bit obsolete, but still, I think it's more or less true still. And whole regions are, I mean, all the regions have a whole large group, millions of people living without being diagnosed. This is very important, frequently shown slide. It's a bit conceptual, but it shows us why it is important to start treatment early. So if we think of having LDL cholesterol, a certain level, and on a time scale, we can talk about LDL burden. So LDL cholesterol concentration times the years of exposure. It's like from tobacco industry, like the pack years. Here we can talk about the LDL burden, LDL times years of exposure. And you need to reach certain threshold in order that you can develop, or at least average person could develop, cardiovascular complications. And in people with heterozygous FH, this threshold is reached around 20 years earlier as compared to person without FH. In homozygous FH, it's already reached on average at the age of 12. If we start with an early intervention, that means in 10-year-old child has introduced statin, we can shift this trajectory of reaching early LDL threshold for cardiovascular diseases to resemble the healthy population. But we need to do it early. If we do it later on, for example, at the age of 18, there's always a little bit of residual cardiovascular risk, and this threshold is reached earlier on. And that's one conceptual reason why FH screening and primary CVD prevention should start in childhood. More recently, this more conceptual figure was to a large extent backed with real-life data. These are the data from the Dutch registry comparing the parents with FH to their children with FH in terms of cardiovascular freedom from cardiovascular events and from death from cardiovascular causes. And we can clearly see here that the children which were early treated are almost 100% free of events and of death, but their parents, which were not treated early, still frequently have, after the age of 30, cardiovascular events, and unfortunately, they might also decease. That's, from a practical perspective, very strong reason why we need to not just discover kids early, but also to treat kids early. And as Kanika already shown today, based on the data from the global registry, only 2.1% of adults registered as a people with FH were diagnosed as a children, so before the age of 18, which is also having in mind the previous figure, kind of alarm information, I would say. What's happening in terms of early detection? So several countries have, I would say, quite a tradition, especially the Netherlands, some of the Northern European countries, as the Norway, parts of Italy, Austria, the Czech Republic. they have tradition of doing cascade screening, detecting, I would say, quite large proportions usually of their populations. Less is happening with universal screening. Our country, Slovenia, has introduced it quite a while ago. There are some pilot attempts in Germany. In Slovakia has a program which is probably not too well implemented. And they're now following several other countries like Croatia, Luxembourg, and many others have already planning that they will start with the program. Why is it, I mean, a great opportunity to do a screening in childhood? In childhood, based on the scientific knowledge, we know that there is a best discrimination between monogenic and multifactorial hypercholesteremia, which means that at a given level of cholesterol, we can be much more sure that a child with such elevation has familial hypercholesteremia and not multifactorial hypercholesteremia. In most population, in most countries, there are population-wide preventive healthy visits, which could be, if we know, I mean, if we are rightly motivated, could be leveraged for the measuring cholesterol and subsequently establishing diagnosis. We also know, based on the slides I showed you before, that early lifestyle and therapeutic interventions must be introduced in the childhood in order to be really effective and also lasting. And it's easy to add, once we have diagnosis in a child, it's easy to add a child sibling or child parent screening. And of course, having a healthy parent is in a child's best interest. So doing FH screening in childhood, we can say that it has a highest impact or high impact on the risk profile of the whole families. Slovenia was, as mentioned, one of the countries where we successfully developed a model of universal screening, which is performed at the age of 5. So all children at the age of 5 have measured total cholesterol. And in second step, if the cholesterol is elevated, they are referred to the Paediatric lipid center, where we perform genetic testing to confirm or exclude the diagnosis. And in the third step, if diagnosis is confirmed, we try to confirm the genetic diagnosis also in a parent with relatively higher level of cholesterol, or in both if it's unclear. And we always give advice that they are referred to adult lipidologist, and that they are immediately, if they have criteria, introduced the treatment. As mentioned today, under the umbrella of FH Europe, some of the programs were selected as best practices by the portal of European Commission. Now we furthermore applied to a call of backing this recognition also with kind of additional financial resources, but the results are pending at this moment, if I'm right, for quite long time now pending. Other steps made to really achieve more, I would say, spread screening programs around Europe. Last year, again, under the coordination of FH Europe, the Slovenian presidency kindly supported the technical meeting on FH screening across Europe, where a broad professional consensus on pediatric FH screening was reached, and public policy recommendations developed, which were published this year. And as kind of, I would say, very important next step, in this September, under the presidency of Czech Republic, another high-level meeting was organized. In the scope of Slovenian meeting, these public policy recommendations were developed. This figure clearly depicts the current situation, they're mostly like opportunistic testing, which means that people are tested if they have like a rare physician, if they are aware, if they have good luck and so on. But this way you can only identify less than 10% of people. You really need a best practice. You need a systematic approach, which means screening is per definition systematic approach. It could be region or nationwide. And this is the only way we can really achieve the desired situation where most of the people would be diagnosed. So I will leave the podium to Nicola now, who will continue with the Prague Declaration.
So just very briefly, and you have actually this in your pack, the publication, the Prague Declaration on FH Paediatric Screening. Essentially, as we heard earlier, it is a call for action for policymakers, decision makers at both European and at national level. It emerged out of the Czech EU presidency meeting that took place in the Czech Senate, and it consists, as well as some very key asks, it includes a comprehensive preamble that actually captures all of the publications and all of the commitments that have been made over the years in the context of FH paediatric screening, and also captures the urgency to act now. And we're looking at 7 specific pillars: political leadership and commitment to make FH paediatric screening a reality, appropriate investment and policy framework for raising awareness amongst medical practitioners and the public to build trust and responsiveness, a comprehensive early detection, screening, diagnosis and life course care program in every country, specific actions to encourage large-scale uptake and subsequent treatment, some targeted R&D to address knowledge gaps, building capacity of healthcare professionals and empowering patient communities on how best to support individuals and families with FH, and a commitment to shared learning and monitoring through international exchange and comparisons both inside and outside the EU. So that is a little bit of a summary of the key asks, but it actually encapsulates the direction of travel that needs to happen for FH paediatric screening to be done systematically and in a structured way across the European Union. And all of the activities that we've been doing over the last 2 or 3 years is culminating in this. And what we want to do this afternoon is to really unpack how do we move forward, taking forward the discussion that we had just before lunch, taking forward some of the elements from Ur's presentation and the potential power of the declaration. How can we as a community move further? This is just a glimpse of the endorsements that we've had, which is very wide ranging, some really, really powerful organisations. There's still some significant gaps that can be filled, including perhaps the Portuguese government. Watch this space. And then we have a number of individual endorsements by notably some key opinion leaders. But again, we're at a starting point rather than an end point. There's still much, much more that can be achieved there. And to note, we have and had the support of the Czech EU presidency, which is the country that is driving all of the other countries of Europe for a 6-month period in terms of agenda, in terms of priorities, etc. Both the minister and the deputy minister signed the declaration, and we heard just a couple of days ago enormous support from the Czech Senate and the Committee on Health, and there's actually been an endorsement there which makes a very, very big case for paediatric screening to become systematic in the Czech Republic. There will be a very important decision in December based on a couple of pilots there, but it just demonstrates how much can be achieved with some advocacy and collaborative lobbying. There's been publications also around the declaration, notably in the GMS Health Innovation and Technology Journal, and obviously the PubMed.gov, the National Library of Medicines, that's open access. So again, more and more individuals, scientists, the community more generally, healthcare professionals, interested parties will hear about what's happening and will hopefully support the cause. And again, we need more prominent individuals, we need more key opinion leaders, we need more policymakers to make a personal, individual, but also institutional commitment to the declaration. So that is really our tool to drive forward the political work at national level. So with all that said, I would just like to suggest now enough talking from us and more action from you guys. We will break out into the working groups as Spella suggested, and we will take a break in about an hour and 15 minutes. Oh, and Magda's pointing out, you can of course also endorse it immediately if you so wish. And Magda's just giving that as an example.
Penina, we want to see you there as a Swedish.
It's done.
Thank you.
Thank you for reminding me of that. So is everybody clear on where you need to go for the afternoon session? So let's move then. Great. See you back here in a little while.
Do we have a second one for my partner in crime? Okay. How important are those lights? I actually didn't go for the singing career because I didn't like Do we need them? No.
Excuse me, I just did this because I have some outlines there.
Fantastic. Are we good? Professor Groschel, are we good?
No, I'm working. Yeah.
Fantastic. Okay. This particular room has got the biggest group because it is the biggest room, and there are some people online. For the people online, I would love to be able to somehow coordinate those people online. Spela. Or maybe, can we project them if there is anyone online? Fantastic. Okay, so I think it's important to say that we have not necessarily rehearsed for that, the two of us. We have not, but we have been working for almost 2 years on this. Yeah, okay. Ladies and gentlemen, in your packs, you have a magical document which is called the Prague Declaration, the little one, very important, because that's a written outcome of the meetings from the past 2 years that took place thanks to community and Ur and other people who really been working for many, many years. Before we start, I would like to highlight one thing, which is, this is a case study, meaning we will be practicing few things to give us certain level of skills, feel for certain things, yet the skills that we will generate and acquire today will be also helpful for any other activities, for elevated LPLA testing, or for HOFH testing, or treatment access, or FCS. So I want to make sure that we do not get limited by the fact that this is a case study of pediatric screening. We can learn quite a lot, but we can apply those learnings to other conditions. It's important that we are very inclusive and that we are as well learning from you. Okay? Or please make sure that you step in because I can own the floor for the next hour.
Just go ahead. Yeah.
Okay, fantastic. So the idea is that we can definitely produce a lot of fantastic guidelines and papers and declarations. All of that is great, but if it's just written and sits somewhere on the shelf, it is a piece of paper. Our job is to see how we can implement it. And for that, we need people like yourself to advocate, to be the ambassadors who will actively help decision makers implement those things. And in our group, we will quickly do roundtable to introduce yourselves very quickly. I am delighted to have with us a fantastic help and support with Yungshu from the World Heart Federation. Yungshu, do you want to just stand up and wave a little bit and say a few words about yourself? And the role you will be playing here today. Just put it there. Yeah, thank you.
Is it working?
Yeah, it's working.
Cool. Hi, everyone. I'm Yun Wang from the World Heart Federation. I work there as a policy and advocacy officer. And we've been working on FH with FH Europe for quite a while now. And we've done a number of collaborations in recent years, including their contribution to our roadmap for cholesterol, but also in our very recently released cholesterol advocacy toolkit. So what we're trying to do is to provide all of you with knowledge, information, but also practical tools to support your advocacy efforts at the local or national level.
Fantastic, thank you. And Yushu is a very, on the contrary to me, as you can tell, he's very, very calm and composed person, but he's got the wealth of knowledge, which is incredible. So thank you, Yungshu, and you are the active participator today. You will be helping us. We also have a new representative from Ireland, from Cree. Ami, do you want to introduce yourself and explain to us what your role will be?
Yes, thank you. Hello, everybody. My name is Annie Costello, and I am the Patient and Community Engagement Lead with CRE, the West of Ireland Cardiac and Stroke Foundation. Many of you may know my boss, Neil Johnson, from other activities, and he has been talking about FH and the importance of raising awareness and advocacy in this area for a long time. So this year it's going to be very much in my own area of work with CRE. So I am very much looking forward to learning. I've learned an awful lot this morning, and I'm continuing to learn and looking forward to engaging with you all over the next while. Thank you.
Fantastic. And your role today is
sorry, as rapporteur, excuse me. Yes.
So you will be taking notes?
I will be taking notes, and I will be checking twice with everybody to make sure before it comes to the reporting back process. So I will be, hopefully, yeah.
Fantastic.
Thank you.
This is the most important role, so we count on you.
Okay, so let's do this quick introduction so we know who we have in the room.
Okay, hello, I am Paula. I am from Ultragenics. We are a pharma company that are starting now working in this area of dyslipidemia. So mainly I'm here to learn. I am the medical representative of the company here in Portugal. And my main goal here is to learn from you, from your experience, and especially get some information on how we can help and support your projects and bring new solutions for patients.
Fantastic. And ladies and gentlemen, I hope you've noticed, Paula is from the industry. She represents a stakeholder group, which is important. They are an important stakeholder in advocacy work. Okay, so we hope to learn from you as well.
Hiya, so I'm a colleague of Paula's. My name is Corinna Crowley, and I'm also part of the patient advocacy team in Ultragenics. But in a former life, I was actually on your side. I used to work for Cancer Research UK. So my previous background, I've done a lot of advocacy work on the patient side. So we're just really happy to be part of the FH family today. Thanks.
Next one, please.
Hi, everybody. My name is Ákos Gesztes from Hungary. I am leading the FH group of the Hungarian Patient Association. I am an FH patient myself. I had a heart attack at 42, been on ECMO for a week. So it's a hard story.
Thank you so much. And before we go to Indy, ladies and gentlemen, the first gentleman who was speaking was Yung-Shu from the World Heart Federation. World Heart Federation 2 years ago, a year and a half produced this document, which is a white paper on cholesterol. And our community contributed to this document. The last gentleman who was just speaking right now is here with his poem, advocating, addressing politicians with a personal story. If you haven't got this document, if you haven't seen it, there are 2 other patient stories, including HOFH story from Lebanon. Please help yourself. Yung-Shu, thank you so much for bringing it from Geneva. We have tools to help us with our policy and advocacy. Next person, please.
Hello everyone, I'm Indy, I'm 17 years old and I'm an FH patient by myself and I come from the Netherlands.
Thank you. We heard you all very loud and clear this morning. Thank you.
Hi, I'm Jill Purver from Action FCS with a patient with FCS and you heard me talk this morning.
Thank you. And this lady actually undersold herself because she did very important 2 trainings for patient ambassadors and advocates. You are a fellow, UPATI fellow, and we will be building on that later on in the afternoon. And you also activated some learning courses with Eurordis. Yes. This is very important. Thank you. Over to you.
Hi everyone, I'm Francesco Fuggetta, I'm from Italy. And I represent ANIF, the Italian Association for FH.
Thank you so much. We will get the translators here to help us.
Bon, désolé, je parle que français. Voilà. Je suis Lionel Rib, président de l'association ANET en France. Je suis porteur d'HF et j'ai été dépisté à 18 ans et mes filles à 3 ans.
I'm Lionel from the French network, ANET, and I was screened at the age of 3, and I am an FH patient.
Sur...
Children also are concerned.
Effectivement, sur ANET, on a déployé le dépistage pédiatrique en France par un grand programme de communication. Et on a commencé effectivement ce travail de plaidoyer en partenariat avec Magda.
FH Europe.
Oui, exact. Tu représentes FH Europe, donc c'est Magda.
At ANET and in France, we have started with the pediatric screening also. We have started a big communication campaign in cooperation, of course, with Magda and FH Europe. Yes, FH Europe, sorry, with the support of Magda, I mean the conductor of FH Europe. And yes, and we started the communication and we are starting also the advocacy program.
Et donc, nous sommes appuyés sur une agence de communication qui a fait un plaidoyer autant dans la presse grand public, professionnelle, et également auprès des politiques et des instances des ministères. Et aujourd'hui, au bout d'un an, on commence à avoir des résultats. Et on commence effectivement à voir la chef apparaître sur les réseaux, à la télé, sur la presse. On a vraiment des résultats qui arrivent.
So we started with all that 1 year ago with a communication company who helped us to concentrate on the most important words that have to be mentioned to base the whole communication on. And since it started 1 year ago, we start having results. FH has been mentioned on the radio, in publications, on TV, and yes, we are very happy with the results.
Je vais arrêter là, sinon je vais passer trop de temps et je vais prendre la parole, alors que c'est important que tout le monde ait la parole. Je pense que j'y reviendrai plus tard. Merci.
And I will stop here because I could speak for hours, but everyone has to speak about it.
So I'm Mafalda Bourbon. You also heard me too this morning, so I'm not going to repeat that. I'm just going to say that I'm also FH Europe member, and I'm a member of the scientific committee and public Magda? Policy committee as well.
Hi, I'm Sally-Ann O'Brien from Amrit Pharma. I'm working in medical affairs with a focus on homozygous FH.
Good afternoon, I'm Marta Saverino, I'm from Italy. I'm the president of another group of patients in Italy that is GPFH. And I work in this association, and then I'm a doctor. I am a FH patient too, and that's all.
Fantastic. So another perspective that we have, a clinician, not necessarily in FH or cardiology or related, but a clinician challenges and a patient herself. Fantastic.
Hi, I'm Cindy Evans. I'm from the UK and I'm a homozygous FH patient.
Hello, my name is Eva. I'm from Bulgaria and I'm representative of Bulgarian Patient Forum organization. We started with our campaign 8 years ago. We made a lot of initiative and screening also, but it's not enough because in Bulgaria we have a very small number of people that treated right now. Our last initiative was in school. We made classes for how important it is to screen everybody for LDL.
Fantastic, thank you so much. And Bulgaria joined FH Europe Network a year ago at the annual meeting, but you are first time now 2 years ago. 2 years ago, and you're finally first time in person, which is great.
Yes, first time in person. We was on Glasgow. I don't remember the year when was create FH patient network, but after that we have different problems, and now we are person for the first time.
Thank you so much. Do we have Ivo? Do we let? Will you be able to translate?
Извинявайте, не знам, не мога да говоря на английски.
I'm sorry, I can speak English.
Аз съм председател на Федерация Български пациентски форум и съм пациент с FH.
I'm chairman of the Federation Bulgarian Patient Forum and I'm FH patient.
И наистина от 2014 година се опитваме да промениме мисленето на нашите политици за това да разберат, че нашето заболяване е сериозно.
We started in 2014 to change the way of thinking of our politicians that our disease is very important.
През 2015 година направихме среща в парламента с нашите политици и така поне направихме малката крачка да вкараме заболяването да бъде покрито, за да се заплаща от нашата каса.
In 2015, we organized roundtable in our parliament, and from that year, National Insurance Fund started to cover biological treatment.
Благодаря. Thank you.
Thank you. There are a few more people online, so we will make sure that you also have a chance to say hello. Janine and Andrea, and then Thanos. Can we hear them? Is it possible to hear them?
Yes. Can you hear me?
Yes.
Yes. I'm Janine from Switzerland. I'm a member of the Swiss FH patient organization. I have elevated Lp(a), and I had my first incident and bypass operation at the age of 60. And since then, I'm advocating and working in Switzerland and together with the FH Europe to raise awareness of genetic dyslipidemias.
Fantastic, and thank you so much for joining us online from Switzerland. Thank you. And Andrea?
Hello from Austria. I am leading the Austrian Patients Organization, and we have already a screening project in Vienna made by Professor Gräber-Platzer, and she intends to extend it all over Austria, and we are working with her together.
Fantastic. And last but not least.
Hello, I'm Thanos from Greece. I represent the Greek Patient Association. I'm also an FH patient. I'm homozygous. I was diagnosed early, and we found the association at 2013, and ever since we're trying to improve the life quality, the access to proper medication here in Greece with the tough financial situations we are in, and we're trying for the best.
We hope so. Is there anyone else on the online? Oh, I didn't realize that there are a few more people. So if Vida wants to speak from Lithuania. Okay, and there is someone with a very interesting name. No, what? No, that's you guys. Okay, fantastic. Thank you so much for the introductions. As I said, it is a very complicated room because it's the biggest room with online participation. We will try to accommodate it as best as we can. Let's break the group.
Yeah, so we'll break the group into the two halves. Or even smaller groups, yeah, and then we can work in a smaller groups. So one will be like the advocates, and other would be decision makers. I'm sorry. We'll break perhaps then into the 4 groups. Perhaps it might be easier to work on the solutions, and two could present the perspective of advocates, and 2 groups could present the perspective of decision makers, and we will try to build a case on both sides. How to I think advocates would need to try to convince the decision makers why it's important and so on, and which arguments should be put on the table to be most convincing. Decision maker will need to ask the right questions, and perhaps to present the right challenges, right obstacles, why that would need to be overcome in order that the screening could be possible in any system.
So to recap, we have heard that many of you work on screening program implementation. Some of you on a city or a region level. Others have national level, and maybe there are some of you who have screening programs ideas and wishes, but those are not yet implemented. So we've heard today good examples of when screening works. We also have heard from Penila and from Shofi what potentially politicians would have to hear. You living with the conditions or advocating for people living with the conditions, we want you to jot down on those post-it key messages. If you had to go and convince someone, speak to a policymaker or a politician on a national, local level. And let me just say, I know that not everyone wants to go to a politician. Hey, you don't know who they are, we don't know where they sit, where their office is. But if you had an opportunity, like today, with Penila, who is in the room, an MEP, a member of the parliament, and if you had to convince her to help and implement pediatric screening, a universal solution, what would you be talking to her about? How would you be articulating your messages? Considering what you've heard today, any of your particular experiences from your countries, we're taking you a little bit out of your comfort zone. This is the first time we are doing it in 3 years that we are meeting, and we're now asking you to work together, and everyone is scratching their heads like, what are they asking us to do? But
perhaps each of us could help two groups on
Yes.
each side of that question.
Fantastic.
And perhaps three or four could be one small group.
So we're taking the two of you out because you will be sort of floating, yes? And we want to make sure that we divide people in different groups. So you cannot be together because you're already from pharma. But we have one person from pharma in each group. We have 3, okay?
Or we can then have only 2 groups.
You want 2 groups?
Should we have 2 groups and they're outside and
Okay.
each of us
So we have,
is helping one group?
Are you happy with that
Yeah,
partition?
that partition is fine.
So
but
this is one partition?
Yeah, but people who are from the same
And this is
organization.
second partition. So we will ask you to work together and jot down some ideas based on your experience, based on stakeholders based on the ideas and the stakeholder groups you are representing. Jot down the ideas. How would you be speaking to a policymaker? Because we will be testing it in a few minutes. We need you to split those. And if you have pens, you need to take the pens, please. I know that there are people online. We will ask you to do sort of a solo workshop. Jot down what you think based on what you have heard. You would be talking to politicians. How would you be? But also at the same time, think what the politicians might be saying. How they might be creating opposition, or maybe they will be in tune with your messages. So I am. Yes. Okay. So this will be the advocates. Yeah. So this will be the group of policy makers, and we will be swapping, so don't worry. So having heard I think I will have to stop talking on the microphone, so I'm so sorry to the people online. This is proving a little bit harder than we initially envisaged.
People online could perhaps add their perspectives once we will discuss the group outcomes, and perhaps they can add their perspectives at the end, perhaps to critically comment both sides or something like this. Yeah. That might be easiest.
I'm almost too scared to check. Do you know what we ask you to do? You don't. Here, this room is the politicians. The good, the bad, and the ugly. Okay, but I just want to work with this group. I don't want to speak to the microphone. Yeah? So for the people online, try to think, what have you picked up today in terms of key messages if you had to articulate it to the policymaker, and also simultaneously or consecutively think or jot down were the hurdles you have experienced or you envisage to experience when talking to politicians. Okay? And we will come back to you when we finish here with the groups for feedback. far more difficult than we planned initially. Indy, can I ask you to come maybe closer? So some of you have different notepads, and if not, you have them posted if we can share those. Basically, based on your experience from advocacy, from patients, and I know that you might not have necessarily worked yet as a politician, but imagine if you did, what would be the things you want to hear, or what evidence do you want to hear, or what...
Okay, are we disturbing the others if we talk to each other?
Because we also
I can hear you.
Hi,
I don't know if
everybody.
the room can hear us, though. If the rest of, you know.
I think the room can hear us.
Oh.
We are online.
Yeah, of course,
okay,
they can
of
turn
course.
the
So
volume down if we disturb them. I mean, they're also talking.
I hope they don't mind.
Well, I can't see any reaction from over there.
I think we cannot go into their action. We have to think about it. And as Urk said, afterwards, maybe give our advice or our ideas.
No, I was just thinking if among us, you know, or between us,
Yes.
we could exchange our thoughts, because I find it a bit difficult just to write down things now on my own. And I find it very useful to have you
to talk to somebody.
Or Anastasios or the two other ladies who were on a minute ago, just to hear what you were thinking.
Yeah, it's a good idea.
I'm running out of ideas. I've heard ideas now, but it would be good to have more ideas. What would you do? Talk to a politician.
So, from what I've experienced all the times I've made meetings with politicians, the most important thing is to be very specific and very quick about it, because they have so many meetings every day with other patient group representatives. They roughly have 15 minutes. And, you know, by 10 minutes, their thinking is already preparing for the next one. So they're not really there. That's the lesson I've learned when I was meeting some. And then the other concern I always had, in this case, we're talking about FH screening in the European level, which is a one-time thing. If they approve it, like in the European Union level, we won't have any problem with it from that day on. But how do you keep contact with a government when they constantly change the format? Politicians change. We have made some good contacts, some good commitments, and then at least here in Greece we also have that kind of problem. The government always changes, and the policies around health conditions and priorities always changes, so it's pretty difficult to keep a stable contact and accomplish things from there. That's my little input.
Do you have any experience, Anna, from, you know, going to politicians and talking?
I've never talked to politicians myself before, because I have been on task now for almost 3 years. And with COVID, we had no possibility to go there. And we also have the same problem that the ministers change. But in Austria now, they are they are overworking a mother-child pass, and I upheld that they should include the LDL testing, LP(a) testing, and triglycerides, and also the Kurt Withalm also upheld to the representatives. He has better connections, so we hope that it will work out, but I don't know what to do more.
Yeah, well, that's a good idea.
And I think the very important thing is that FH can be detected so easily with only one blood testing, LDL and LP(a), and you could help so many people with that. And I think that would be a good argument to include it in such a mother-child pass. or later on in a youth pass, which is not yet established in Austria.
Seems a good idea, yeah. Yeah.
Sure.
I was just
And
wondering,
what's your experience, Janine? Do you
my
have any,
experience, I don't have
what's
any
your
practical
ideas, maybe?
experience. For the last 2.5 years, as Anna said, it was very difficult to do anything really hands-on. But I've learned a lot from FH Europe and all these activities which have been presented. So I'm now trying to think how can we put it into practice in our country. And we have been approached by our heart organization. We had a presentation there because they have got more money, they are bigger, etc. But we've never heard again from them. So I've been trying a couple of times to re-establish contact, and I got no idea why they stopped, because they approached us. So I'm not quite sure. I think there is still the idea of not of prevention, but of healing, in the sense of not to prevent the preventable, but to sort of avoid the worst when the incident has happened. And so I'm also thinking of joining together with other organizations within our country, because then we have more power to do lobbying, I believe.
That's a good idea of connecting also with this heart association. But you must be aware that everybody is working voluntarily, or are they full-time?
I mean, they have full-time staff.
Oh yeah, because we are doing it voluntarily, and so we don't have much time, and we don't have persons who are experienced. So it is a process, I think.
We have the same problem. I mean, we are about 2, not even 3 people now, only 2 at the moment who are active in our association. So it becomes very difficult. And personally, I've been ill for the last 6 months. So I'm better now. So, well, I had heart insufficiency. So I found it very difficult to do my everyday sort of jobs, let alone FH Europe. So now I'm back. But that's a problem in our associations, I believe. We don't have enough staff. We don't have people who are paid or have enough time to do it. And therefore, if, as you say, we have to find ways of having the biggest possible effect with the least necessary input, or, you know.
We also work together with the Rare Disease Association in Austria. And they are very active. And yeah, the Heart Association, I had a contact only this summer, but I was not able yet to continue. And one should have more activities together, I think, with the heart associations.
I think so too, yes. It just seems that or the atherosclerosis associations in the various countries.
Yes, yes.
Those would also be.
We're also working together with them. With
Sorry, just to add that, we also in Greece follow the Rare Patient Association as well. It works as a network, as an umbrella, and we also have atherosclerosis. So it looks like it's the best way to search for alliances in order to grow in numbers, get some fundings, maybe some help. Anyway, sorry, Anna.
No, it's okay, Danos. It's very good that you added it, because the alliance with the Atherosclerosis Society is very important. And they run the FH registry in Austria.
Oh, that's very good.
Yeah, Greece as well. Well, they were the first one to help FH Europe, put FH Europe under their wing. When they had an annual congress, they would invite us to make our first meetings there as an entity. So it's pretty clear that every time they find on a national level some individuals or a newfound patient group, they will always be there to support them, even financially sometimes. Or just maybe, maybe for the simplest of help, like paying a secretary for keeping, every time you meet, she writes and keeps, how do I say it? Sorry, I forgot the word. I'm not in the best condition.
The protocol?
Anyway,
Or,
protocol, yes, anything.
or a report?
Yeah, sorry?
Protocol or report or what?
Reports of the meetings. Yeah, I keep reports, take notes of the meetings, stuff like that. In anything that they could help, they could. So, or give you material for your website if you're planning to make one. Later on, if you grow up, numbers. Anyway, so about the subject we were talking. Because
trying to give ideas what we can do.
Yeah.
What I thought, what you mentioned, Anastasis, is about these short information, and so we have these snappy slogans like "every minute a child is born with FH," or what is probably even more. We didn't really mention it here, but if we assume that 25% of all the people have got elevated Lp(a), that's even a bigger number. So to use numbers, to short messages with how many people, how many lives can be solved, and cost. Because in our country at the moment, it's a big thing. I mean, our premiums for health insurance will go up by 10% again now, or at least. It depends on regional differences, but we have a tremendous increase in premiums which people have to pay because it's you pay that privately, and it's not related to income, it's per head. So that will be a big problem now, and there's always a discussion: can we reduce cost in the health care system? And I think that would really be a very strong argument, but I don't know whether politicians are interested in that, because it only works out in the long term. Because if we help children now to avoid the consequences of FH, it will only work out in 20, 30 years. So politicians want short-term success. So I don't know how to, whether that is an argument. Did you find that useful to mention cost? And
I think that's an argument for the stakeholders of the Gesundheitssystem, of the system, of the I don't know, social security or so, of the stakeholders from social security system.
Yes, well, these are private health insurance companies, and in
Austria it's not private.
That's better. Then you have the state has more influence then. Yeah. Or what about working with the public? Like this gentleman from France, he said something about they've used a professional, I don't know, PR company or whatever. And since then, FH has been mentioned more and more in the media in France. Do you work with the media?
Not really.
Sometimes, if we're hosting an event, like on the International FH Day, we may release, make a press release and allocate it to a national or a local channel. They will play the news so that people can see. They can come and take some brochures, get informed about the FH. So in that kind of term, yes, we have collaboration with the media sometimes, but that's very situational.
And I think that's very functional. It's only once in a long time. But as this gentleman from France said, they have a campaign, I think it was. Because normally when you say FH in Austria, it is connected to Fachhochschule.
Same in Switzerland.
Nobody,
So it's college, you know.
or only few people know that it is a familiar hypercholesterolemia.
Yeah, no,
So-
that means college, so it's a completely different context. It's,
So I have already
university,
thought about
university.
I have already thought about making big posters like no, publicity posters, big posters for a campaign, and make a national campaign with the FH ambassadors, for example.
Yeah, that's the next topic probably. Do you
Yes.
have a lot
Yes,
of
it will
ambassadors
be. It
in
will be.
Austria?
But I think we must work on many different ways, and it's not so easy.
But I'm very grateful for FH Europe and also for you. I met you online on various occasions, and I found it very inspiring because you see what other people are doing. And I've also been able to use some of the statistical material and other things from FH Europe, which I found very useful because, you know, it's a lot of information. And so, yes, I think it's great that we have this network so that we can help each other.
That's absolutely right. And also the campaigns they prepare, and we can use as national organizations, and we don't have to work it out, just take it and use it. What do you say, Danos?
A toolkit, like a toolkit?
Yes.
Yeah, exactly. That would be very useful to have, of course.
They were talking about a toolkit, weren't they, at some stage? So I don't know whether you've heard anything about that. You know, a toolkit which with material which we can then use, but I haven't received anything or heard anything yet.
Do you have a contact of Spella?
Well, I have a little exchange with Spella, but I have not. You think that she would have something like that?
You can ask. You can always ask. They were talking about having a toolbox. A toolkit. Sorry, toolkit. So I don't know if that was implemented, but it doesn't hurt to ask. And what I know is that the ambassador training program they're planning to have, or that was a thought, at least, to have all the training sessions recorded, so all the new ambassadors coming, you know, the new waves can get retrained from that again and again, and always updated, you know, with new information, stuff like that. That would be something, but yeah.
Yeah. You said about ambassadors, Anna. Do you have a lot of ambassadors in Austria, which you could use to send out?
I have 3 people attending in Lisbon from Austria. Lena Rosa, and she is very disappointed that Danos is not here. And her father and Caroline, and maybe they will act as ambassadors. But we will see.
And are they trained? Because that is also the thing. Magda said something about training the ambassadors. Have they already received training, or have you received any training?
You will probably know more because that's the next session we're going to cover, but that was the whole idea. Well, technically, I didn't have a training, like a proper training, because when FH Europe started, we were some of the first people to get involved, and there wasn't any kind of, how do I say, training. Everything I've learned from experience. And hopefully the new ambassadors won't learn it that way. They will have some guidance along the way. It's very useful because usually most people coming from backgrounds, they have nothing to do with media, contacts, politicians, anything. And it's so so hard to adjust to the situations and know, be better speaker or know what to tell and what not to tell. I did have some kind of training, which I mostly forgot many things. That was paid by some pharma industry that they were also sponsoring the Greek Patient Association. It had to do most with organizing campaigns or being more efficient with your speeches, stuff like that.
I think you are already very good, Stanos.
No, I don't think so. I used to be better, but now, lately, I don't know why. I had the fright. Maybe after COVID, especially giving live speeches, I'm like, I'm kind of, I used to do it more, now I'm more shy, I guess.
But also the moderation you did on the webinar was very good.
No,
yes,
that was,
yes,
that was really
you did
bad.
it well. Yeah.
No, but it's good that I find it always very interesting to have people like you two who have to share the experience, and when you do the moderation, you know what you're talking about because you've experienced it yourself. So that's.
Yeah, well, in this case, specifically about the last webinar, yeah, I'm not that proud because truth is I wasn't expecting to be the moderator. I had to learn a few things beforehand. I didn't find the time, and it was, I was kind of stressed sometimes. I just didn't know what to tell. I was very, yeah, it wasn't probably my best moment, but if you say you're fine, I take your word for it.
Yes, yes. You were very natural, Nobody is perfect. Nobody is perfect. And that's the way how you act, how you acted. You were normal, not studied in beforehand, but
really
only Thanos.
Yeah.
Very sympathetic.
Thank you. Well, I did have a different impression about that, but thank you very much. That was very kind to hear.
Nothing to thank you.
No, but nevertheless, we can all, it would be useful to all of us if we have more tips and advice and maybe training or whatever on how to approach politicians, how to approach people who are in the health care system, even doctors, because it would be great if we could have access to a university lecture and as a guest speaker or something like that to bring in for young doctors, to bring in the patient aspect of the risks of heart disease and all these things. So it would help us, of course, anything that could give us more ideas. I know that Magda now with this discussion wants to have ideas from us.
So about that, we made our own group. The others have like 5, 6, 7 members on each group. We are a happy group of 3 online. So
right.
Some arguments I've heard right now is from Anna. You said some very good arguments.
It said it's very easy detected and can
not really expensive to do
not expensive and helps a lot to prevent the heart disease.
Yeah,
we can add that, and also what you said, Janine.
Yes, I'm just trying to find out. What I found very interesting, and that was also said by the Swedish politician, and you said it, we have to be specific and we have very little time. What I would add to that is I like to work with graphics, with visual, with pictures, because there you can pass your message on within a short time, and it sticks because images stick to the mind. So for instance, if you say like a third of, well, most people would die of heart or of CVD. So if you can actually catch those before it gets to that stage, or before it gets to a sort of, with little graphics, just to make it so simple that with a few pictures, you can pass the message on. That's one thing which I found useful in the past.
So your suggestion, if I'm hearing correct, is to make the actual meeting, which is usually a dialogue, and maybe the secretary keeps note of the meeting. You suggest that it should rather be a meeting, but also a presentation, like a presentation.
A presentation.
Visual. Yes. So,
yeah.
Like something you would on a company meeting or something. Okay, interesting. See, for instance, I've never thought of that. We always went there. We had sent a release to the politicians. We made the meetings. We set our points, like tricky points, on what we want from that meeting. But I've never thought of actually making.
So if anyone has got a moderator job, do not offer it to me. It's a disaster at moderating. I don't even know what time we're supposed to be doing the next part anymore. In 15 minutes is the break.
Go mute now.
Okay. So yes. So what we were supposed to do is we were all supposed to hear, at least physically in the room, practice. What would it be like to be a politician or policymaker, two different things actually, and an advocate, and then have a role play? So someone is actually pretending to be a politician and the other one is an advocate. We got this far as we split the groups. We had one group talking about advocacy and the other group talking about advocacy, and plenty of ideas. So I think we need to now cross-pollinate and bring here the rapporteur to brief back the other team, but also from here this team to brief back the rapporteur, and more importantly, a round of applause for the remote group working together. We need to hear from you guys what you discussed. There is, however, one other thing which I will feel completely obliged to do, because Nicola otherwise will crucify us, is to put here on the whiteboard something. And the question was, what is one thing that you found today, new, unusual, groundbreaking discovery about this whole concept of pediatric screening? Is there anything at all? I'm going to read the question because I have it. We still have one more session to moderate. We better get cracking. Just 1 second, bear with me. So, that was supposed to be the icebreaker question. What is the most surprising thing you have learned today about the FH Europe pediatric screening campaign? So that's one thing. So if we can ask you to use the post-it to write this one thing that you've learned, while we have as well, and Annie, report back to us from her little group, and then from this little group, can we have one volunteer who will speak on all those floating ideas that we had in this room? Otherwise, I will identify a volunteer. Jill, and then from the remote group, we will have, because there's 3 of you, I think you will identify one person who can speak on behalf of this group. Is that okay? So the task is, we write down one most surprising thing we learned. Annie is reporting back from her group, advocates. This group, Jill, represents the politicians. Yes, I don't know how we're going to do that. Yes, and then the remote group. And if we still have some time, we will just maybe play a role, yeah, if we have time. So, Annie, over to you.
Okay, perfect. Please feel free to jump in if you think I've gotten it back to front. So our problem was to introduce a policymaker to the problem and try and win them over to our side. So I think we thought that the best place to start was with the big picture for a start, that cardiovascular disease is the leading cause of death worldwide. Within that, then, we are focusing on FH, which is a specific condition, and with it needs a specific approach, and it is presents very high risk. So then we wanted to come at it from the scientific evidence. So the first thing to note, I suppose, is that it is not a lifestyle-related condition. It is an inherited disease, and the person does not have a choice in the matter. So that's the very first thing. It is genetic, but common, and we can show this with the data. We have data to prove this. 1 child per minute is born with FH.
How prevalent is the condition?
1 per minute. So we have some data to show you from a little town in Lithuania where we ran a. I'm not going to give you. This is what we might think we can do. So this is something we could do. So if we were speaking to you, we would have done this work. 1 in 300. Okay. So in terms of the scientific evidence and the evidence that we can show politicians who are primarily focused on costs. We can prove that the costs of the of early intervention will have a direct impact on the financial implications, that somebody who may live longer, who is diagnosed later, if they were to have an event or something like that, that would obviously incur much more cost for them and for the health system generally. The goal again is for healthy children. I'm kind of losing the run of myself a little bit here now. I think I was writing all over the place. I can't remember if this was. Okay, I suppose back to the scientific piece. Yes, we were talking about how easy it was to diagnose, and if we were to have an early years approach, at what point would be the most optimal age range to screen. So it would be somewhere between the years of 1 and 9. It's country specific if we were deciding to implement a screening program. So somewhere along there we can prove, because we have the Dutch data to prove this, and so we can. Sorry, I keep looking at you to make sure that I'm along the right track. So that if we are asked to prove this, we can show the data to give an example of how treatment can completely change the outcome for a family. And it is about family health, and that if even if somebody is diagnosed at 35 years old, that maybe they have likely a child who might be 3 years of age. So therefore you're saving 2 people, you're giving the child its parent, and the parent is getting to live long enough to bring up their child, and kids need parents. In terms of having the scientific data at our behest, we know then that we can ensure the politicians that we are treating the right group of people at the right time across the right spectrum of their life. So moving on from the scientific side of things as kind of the first port of call, and making sure that we have all of that correct and can speak to it with confidence, we move on to the messaging. In terms of communicating that not only to politicians on a human level and then to the general public. So again, back to the 1 child per minute, that behind every number, there is not just one person, but there are several people. And in trying to convey this message, it could be that we use videos as part of a campaign with children, telling the story from the child's perspective, back to the 35-year-old and maybe the well, maybe not quite the 3-year-old, but someone a little bit older than that. So compelling stories that will make people stop and stand and listen for a moment and take notice of the fact that this is a real condition and there are real people behind it. And if it was your child, what would you do? And then involve the media as well was the other thing. And then I guess as a follow-on from that, to utilize ambassadors or champions. Sometimes somebody has said here it might be tricky to find people that will stand up and say, yes, I have it. Somebody in the political field, somebody maybe who is a policymaker, somebody who is an influencer or a famous sports person, something like that. All these kind of people would have a very big role to play in raising awareness and kind of getting people on side. Patients associations and healthcare professionals must be aligned on the messaging. They must, be on the same page in terms of what the message is. If we're to bring everybody along with us, and within, if we take the kind of the different layers of stakeholders and take the medical physicians, there are several layers of stakeholders, and within that.
Annie, so I'm just going to ask you here, because I'm worried that this group won't have a chance to contribute because you will cover everything.
Oh, sorry.
She's new, first time at an FH Europe meeting, and she's already having a strategy. I mean, fantastic.
I'm only the voice of the group.
Fantastic. So I'm going to be the devil's advocate here, and I'm going to say, hey, politicians, have you heard what you would be looking for from Emmy, what she said? Has she covered some of the topics that we thought were interesting from a politician perspective? Before we debrief. Anyone wants to comment?
I mean, we had a couple of things from a politician's perspective. We had, tell me how I can help save lives. And I think you had that, though. The one thing I would say with starting with cardiovascular broadly, when you don't know a lot about it, makes me think of disease-modifying obesity and not genetically related things, which is a different piece. The other thing is help me save money, which you came to. And then the other, well, you referred, you said that you would have some costings on.
Yeah, we can come back to you on that.
Yeah, you can, in the follow-up meeting. And then the third thing that'd be lovely to hear is how will you help me get a profile for doing the good work? That was just something.
Okay, so as politicians, we started off saying what we would want to hear, and it was cost-effective, self-interest, and things you just said. And then we slightly slipped, actually, into hearing from France about having tried all of this stuff, and it didn't work in a lot of it. Yeah, so... and one of the difficulties were that if you find somebody in Parliament, the Parliament changes, the politician changes. It's very difficult to find somebody who can work with in a sustained period, and that's difficult. So it's really important to know who's in power and who has a vested interest in the condition. I think what we came to, just to be very brief actually, was that actually we need a coordinated package of resources really to talk to the person or to actually, as a European-wide kind of big group of people, try to shame our governments into recognizing where they fit within a kind of European-wide table. I think that was the kind of most popular thing that we came up with, and having like a kind of traffic lights about where you fitted into that list as a way of trying to galvanize action on a countrywide basis. And we talked about what the European Commission could do about that, and actually we're waiting for the European Commission to make its policy funding thing. So that's part of what this is all about, actually, so we discovered. I think that's kind of where we got to, actually. So we didn't end up being politicians. We ended up kind of just saying how difficult it was to break through to politicians again. So, but I think the main thing was about doing it coordinatedly, so that we all had the same kind of message that we were giving, but we'd have to adapt it to our personal locations.
Thank you for that. And can we bring the team online to share your thoughts, please?
Well, who would like to?
Anyone? Janine, go. Sorry.
Okay, well, I tried. We tried to look at both things, but as we are more on the patient side, we spoke more about that and tried to find out what can we do. And your first question was, what is the most striking thing for us? And we thought, well, the thing that every minute a child is born with FH, I think that's something which is snappy, catches attention, and could be used in a contact with politicians. Then we also came to the conclusion that when you approach politicians, you have to be very specific. They have very little time. Sometimes it's only a matter of 10 minutes, and then the next lobby group waits at the doorstep. So it has to be short and, convincing, and it has to stick, possibly with some graphic or visual tools. And then that was Anastasios telling us, and then Anna said the arguments are FH is easily detected. It is not expensive to do the screening, and it has a big effect. So we got 3 trumps in our hands, arguments which could persuade politicians. That was about yes, and then we came to, probably that will be discussed next this afternoon. We were talking about, if we do that, we would be grateful for a toolkit for training, for advice, but I believe that is more than the ambassador.
Exactly. Yes.
But that's what we thought. Well, if we do lobbying work, we need to know how to do it and learn from professionals, because most of us are not from that sort of we are not PR professionals.
Fantastic. And I wanted to say thank you, because the 3 groups have contributed with a lot of thinking and the outcomes of thinking that we as a collective have missed for the past 3 years. And I'm going to do those sort of bow towards the sponsors and the pharmaceutical companies here, because we've been asking for supporting the ambassador program. And we've been talking about it for probably 2 years now. But we were, as FH Europe, missing this collective buy-in, this group, as all of us together, to come to the conclusion that we need it. And we need to be beyond talking about it, we need something specific. So I wanted to comment quickly and say that the World Heart Federation has officially confirmed that they will be working with us together. Actually, officially, no. I have a confirmation from 3 people from the World Heart Federation, but we will make it official, that they would like to work with us on the ambassador program. The toolkit that Yunshu has with his group produced and published a week ago on Friday, is it correct? Is exactly this, step by step. Do this, A. B, don't do this, say that. When you do that, say this. The only thing we need to do now as a community is to fill in the gaps when it says, for the scientific data, we have Lancet publication, global registry data, Kanika Imperial College data for adults, children. When it comes to stories, we have Indy, we have Marta, we have Lionel. Just to give examples, we have your beautiful poem. When it comes to cost effectiveness, Professor Groschel, how much does it cost to do a cholesterol test in a child? €2. €2. We heard earlier that it's not necessarily obstructing the healthcare system. So what we need to do is take the notes that Annie has so beautifully jotted down, take the example of the toolkit and cross-pollinate it with examples. So this is what we started doing already at FH Europe with the ambassador program. And that's the next workshop to say, you know, what type of information? Is the political space the only space we want to advocate? What about all other needs? Treatment development, access to treatment. Yeah? And so on and so forth. So we will cover it in the second session. How are we doing on time? Time for the break? They're probably breaking already, the other groups. Can I just ask, or do you feel we got to a point where we as moderators feel complete?
Yes, I think there was many layers were uncovered. Perhaps it was too difficult task to really reach, I would say, one line of conclusions. But I think these discussions were very valuable and very rich. So I'm quite happy with it. I don't know. Yeah.
I just have one quick question, actually. Has there ever been a costing done of €2 compared to no treatment heart attack? Because that would be very, very stark.
Many studies are there already existing, and all that was done is clearly showing a huge or large margin cost effectiveness.
But again, I think the learning is we need to bring this knowledge. So I feel like FH Europe community, as in the advisors, the scientists, some of us, we have that. What we haven't done yet is told you that we have it, and we haven't brought it to you in a format that you understand. You feel it's like, we have a car for you, but we need to tell you that we have a car. We have the petrol, and we need to teach you to drive it. And you need to tell us how the driving experience feels, because maybe we need to adjust it to your specific roads in France. On that note, please, I beg you, put those post-it on this whiteboard, anything, because Nicola is just going to crucify us. And let's have a break, 15 minutes. I want to say thank you so much, Anandrea, Janine, and Thanos. You made very good points. So we're meeting back in 15 minutes, and there's going to be a presentation by Neil Johnson. Thank you. I think you're such a great moderator.
See you later.
Later, I'm gonna drink something to stay awake.